This is the agenda I will follow. I will talk a bit about the treatment objectives, dryness, systemic treatment, the EULAR recommendations, and some new biological therapies that are emerging for Sjögren syndrome. And finally, the evaluation of the response to treatment. The therapeutic management of Sjögren's has not changed much in recent years. And it's also important to mention that there are no disease-modifying drugs. Instead, the treatment at this time is symptomatic. The treatment of dryness is mainly based on muscarinic agonists. And when severe systemic manifestations appear, then we do use immunosuppressants. The main goals are to improve the patient's dryness and to prevent complications from this dryness, such as infections, cavities, corneal ulcers. Multidisciplinary management with rheumatologists and ophthalmologists is very important, as well as with specialists in oral medicine, and most importantly, and this is what I want you to take away, the fundamental pillar of Sjögren's treatment is based on protection, stimulation, and substitution. Speaking a bit about non-pharmacological and preventive interventions for Sjögren's syndrome, it's important to preserve tears and maintain oral hygiene, as well as to avoid stress, engage in physical exercise, and get enough sleep. It's also very important to absolutely quit smoking and definitely maintain a proper and healthy diet, especially one based on the Mediterranean diet, which is rich in fatty acids. Also worth mentioning is that at next year's National Congress, our chief, Dr. Rosas, will be speaking at the Sjögren's panel. There will be a talk on the microbiota, which, as you know, is a very trending topic. So yes, there will be a panel on microbiota in the context of Sjögren's syndrome. And how do we treat dryness? Well, I'm going to start by explaining ocular dryness, especially first-line management. Controlling the environment, avoiding dry or polluted settings, also reducing screen time, such as computers, mobile phones, and the use of glasses can also be helpful in your daily routine. Avoid toxic drugs such as antihistamines, antidepressants, and tricyclics. And it will be based on the use of topical agents and punctal plugs in refractory cases. As for eye drops, we have several active ingredients. We have hyaluronic acid, which improves eye dryness, and corticosteroids, which have been shown to be more effective than NSAIDs, although they also have side effects. As you well know, increased intraocular pressure and cataracts are associated, and NSAIDs have more side effects such as corneal and scleral melting, perforation, ulceration, and keratopathy. We also have cyclosporine, which has also been shown to improve dryness. There are other treatments as well, such as tarsorrhaphy, which is a surgical technique. To close the eyelid, there are also injections of stem cells into the lacrimal glands, as well as therapeutic contact lenses and autologous serum tears. These are the EULAR recommendations, which, following an evaluation of dryness, are divided into severe and non-severe dryness. In cases of non-severe dryness, we will start with first-line treatment using artificial tears and ointments. And when we are dealing with severe dryness, we would then apply topical corticosteroids. If there is no response, or if a very continuous dose of glucocorticoids is needed, we would move on to cyclosporine. If there is still no response, we would proceed to autologous serum. And finally, in cases that are refractory to antimuscarinic drugs, or, as I mentioned earlier, lacrimal plugs. I wanted to bring a few examples of drops that are used. Icebis is cyclosporine at 0.1%. Then we have Endoret, which are autologous serum drops. Then we have Softacor, which is hydrocortisone. I also wanted to mention that hydrocortisone is superior to dexamethasone because it has a more localized effect. And since it doesn't penetrate into the eye, it doesn't cause as much elevation in intraocular pressure or lead to cataracts. And well, there are many artificial tears available. I wanted to bring a few examples. And now we move on to dry mouth, which we also divide into mild and severe. For mild cases, we start with general measures such as staying hydrated, avoiding sugar, and avoiding dry environments. Also, avoiding drying medications and aerosol humidifiers can also be used. Also, in these patients, Salivary stimulation is also interesting, which can be non-pharmacological, using chewing gum or candies, always sugar-free, or pharmacological, which I will explain now, later. And in cases of severe dry mouth, saliva substitutes will indeed be necessary. It has no adverse effects, improves symptoms, the pH should be neutral, and it should contain fluoride, resembling the natural saliva in the mouth. Some substances that can be used include hydroxyethyl cellulose and chlorhexidine, and the dental plaque should be fluoridated, especially to prevent cavities, which are a common complication in these patients. Saliva substitutes can come in the form of sprays, gels, or rinses as well. Here, I also wanted to include the cellular recommendations for dry mouth, which, as we've mentioned, also depend on the severity in mild cases. Non-pharmacological stimulation for mild cases, and both non-pharmacological and pharmacological stimulation for moderate cases. And in severe cases, we will then use a saliva replacement. And how do we carry out this pharmacological stimulation? Well, always after an evaluation, because we must make sure that there is functional reserve. The treatment will be with pilocarpine or cevimeline. However, cevimeline is not marketed in Spain and in some other countries, so the most commonly used is pilocarpine. It has been shown to improve dryness in the eyes, mouth, and skin. Its effect appears mainly within the first hour and lasts about 3 hours, then decreases. Candidiasis may occur, and it can have some side effects such as increased sweating, more frequent urination, and flushing. However, I also wanted to mention that pilocarpine has been used in our clinics for many years, and we have never had any significant adverse effects. And, as Carmen mentioned, it should not be used in patients with asthma or COPD. Other types of dryness that we can treat include nasal dryness, using humidifiers and saline nasal sprays, which come in various strengths. We should always start with the children's version, which has the lowest strength, to ensure greater comfort for the patients. For vaginal dryness, we can use topical moisturizers and lubricants, estrogens, hyaluronic acid, and hormone replacement therapy. And in this case, it has been shown that pilocarpine is not effective for vaginal dryness. In the case of the skin, we can use gentle cleansers, moisturizers, and avoid excessive washing of the skin. And regarding laryngotracheal dryness, treating gastroesophageal reflux is also important in these patients. Moving on to systemic treatment, it's important to note that it should be tailored primarily to the severity of the patient's organ involvement. And according to the SDAI, as Carmen mentioned, an SDAI greater than 5 already indicates moderate disease activity. Patients with active systemic disease should be managed with a sequential approach. As with most autoimmune diseases, we treat in the clinic, starting with glucocorticoids, followed by immunosuppressants, and finally biologics. And it's worth mentioning that some systemic manifestations are not included in the SDA and therefore will require specific management, such as congenital heart block, pulmonary hypertension, Raynaud's phenomenon, etc. I'm not going to go too deep into the characteristics of these drugs because you all know their properties. I'll just mention that, as you know, corticosteroids have their side effects. Therefore, we should always use them at the lowest possible dose for the shortest possible time. In patients with Sjögren, it has been observed that there is a subjective improvement without objective evidence in the tests. And well, that's that. Antimalarials, such as hydroxychloroquine, have been shown to improve both clinical symptoms and glandular function, as well as oral infections, joint issues, muscle problems, and fatigue. But not only do they improve the patient's symptoms, they also lead to analytical improvement with better lab parameter results. Therefore, the use of hydroxychloroquine in Sjögren's syndrome seems to be of interest. Moving on to immunosuppressants, as you all know, they are corticosteroid-sparing agents, and no one has been shown to be superior to another in Sjögren's. Nor is there sufficient information available regarding the dosage and treatment of immunosuppressants in these patients. Therefore, as always, individualization is very important. And now, moving on to biological drugs, a group of experts from the SCR gathered to review, to develop recommendations regarding these drugs in patients with Sjögren's. I will start with anti-TNF-alpha agents, for which they concluded that they are not effective in Sjögren's. Rituximab, has been shown to produce an improvement of between 60% and 100% in systemic features, reduce intraglandular and musculoskeletal manifestations, and also lead to an improvement in the SDAI. Additionally, as you know, it is a good glucocorticoid-sparing agent. Therefore, rituximab does appear to be a promising option for patients who are refractory to immunosuppressants. Moving on to belimumab, an improvement in the SDII was also observed, along with a reduction in parotid inflammation, and among 5 patients who were refractory to rituximab, 3 of them did respond to belimumab. Therefore, it also appears to be a good option for these patients. Regarding abatacept and tocilizumab, abatacept is indeed recommended in refractory cases, especially those unresponsive to rituximab, but tocilizumab, given the lack of evidence, is not, a consensus has not been reached. It is not recommended for patients with Sjögren's. I'm now going to move on to the 2019 EULAR recommendations, which, as you know, EULAR divides the treatment of Sjögren's syndrome by domains. I'll go over the most important ones. I won't go into each and every one of them. I'll start with the management of glandular involvement. As we mentioned, it will be symptomatic. Then glucocorticoids can be considered, and later rituximab or belimumab. In cases of joint involvement, when there is mild joint involvement affecting fewer than 5 joints or just arthralgias, we can start with anti-inflammatories and hydroxychloroquine. And in cases where more than 5 joints are affected, in addition to hydroxychloroquine or corticosteroids, we can consider immunosuppressants, and as a last option, rituximab or abatacept. In cutaneous involvement, we have 2 types of manifestations: annular erythema. If it is localized, we can use topical glucocorticoids, and if it is diffuse, we can use hydroxychloroquine and corticosteroids. And in cases of refractoriness, consider other antimalarials. And in the case of cutaneous vasculitis, EULAR recommends the use of glucocorticoids, immunosuppressants, or rituximab. And finally, we can consider plasmapheresis. And just to wrap things up a bit, the most common manifestations, also mentioning pulmonary involvement, in which we will use glucocorticoids, immunosuppressants, cyclophosphamide, or rituximab. I wanted to comment on this slide about both peripheral neuropathy and hematologic involvement, which EULAR addresses. Already, as a first-line treatment, intravenous immunoglobulins are used in its management. And also regarding congenital heart block associated with anti-Ro antibodies, just to mention that in complete block, which is 3rd degree, management should include intravenous immunoglobulins, corticosteroids, and also plasmapheresis. This is a summary table simply for you to have as reference material. And then to mention that lately many new therapies are emerging for Sjögren's, or rather, many therapies are being studied. Their main target is the B cell, particularly anti-CD20 antibodies, and especially those that target the signaling of the B cell activating factor, which is BAF. We also have therapies that target anti-CD40, which is involved in the interaction between T cells and B cells. And also, we have drugs that act on Bruton's tyrosine kinase. This slide is simply to familiarize you with the names, because these are therapies that are already gaining attention. Nipocalimab was already discussed at the ACR, at this past ACR, just a month ago in 2024. Ianalumab is a BAF, as I mentioned earlier, and iscalimab and dazodalibep act against CD40. So yes, just to get you familiar with the names, because it really seems like they are showing a response, and they are receiving positive reception in the studies being conducted. These are all the clinical studies currently underway, those in development, so you can see what's coming our way. And finally, to talk a bit about evaluating treatment response, because the SDAI is used to assess treatment response, but it has its limitations. It measures current activity, not past activity, regardless of its severity. For example, a patient who had lymphoma years ago, well, the SDAI does not capture that and does not take it into account when evaluating treatment response. In fact, in clinical trials, it does not show improvement of the drugs compared to placebo. And this may be because it does not include aspects like esprit, glandular function, etc. Therefore, we have the STAR, which is the index currently used. It has 5 domains: systemic activity, patient assessment using the SPRI, as well as glandular function, lacrimal and salivary, and finally, a biological domain. It's worth mentioning that the STAR response criterion is as follows. There is a response to treatment when the score is of 5 points. And finally, a few conclusions to wrap up. As I mentioned, what I really want you to take away is that the treatment of Sjögren's is based on 3 fundamental pillars: protect, stimulate, and replace. The treatment for dry eyes and dry mouth hasn't changed much in recent years, but it's true that new therapies are emerging that seem promising. Systemic treatment, as I mentioned, should be based primarily on the sequence glucocorticoids, DMARDs, and biologics. B-cell targeted therapies such as rituximab or belimumab have indeed been shown to be the most promising therapeutic approach. And in fact, as I mentioned, the drugs currently being studied also act on these cells. And to assess the disease, we use the SDI. However, for evaluating the response to biological treatment, new indices have emerged, with STAR being the most commonly used at present.